Hi, everyone. Welcome to Arthritis at Home. My name is Cheryl Cohen. I'm with Arthritis Consumer Experts, who hosts Arthritis at Home. It is my incredible pleasure to welcome to the program this hot rising superstar, newly minted PhD, Dr. Kayte Andersen. Welcome to the program, Kayte. May I call you Kayte?
Yes, please
Okay.
do, and thank you for having me.
It's wonderful to see you, and I know this is going to be a really useful conversation, and our audience will figure out why in a second. But first, let me introduce you more fully. Dr. Andersen recently earned her PhD in epidemiology with a certificate in pharmacoepidemiology and drug safety from the Johns Hopkins Bloomberg School of Public Health. And we know from the pandemic that Johns Hopkins has been a driver, one of the key data warehouses for looking at questions about what's happening to people with autoimmune types of arthritis during the pandemic. Dr. Andersen also holds a bachelor degree in pharmacology and a master's degree in pharmacoepidemiology, both from McGill University here in Canada, in Montreal. Kayte, you had initially planned to study PCSK9 inhibitors for your doctoral work, but you pivoted, and I love that word, you pivoted instead to working to understand the safety and effectiveness of medications for adults that have been hospitalized due to COVID. So I guess where I want to start is, tell us why the pivot.
I think it was a mixture of both responsibility and opportunity, I felt. I got involved on March 23rd, 2020, so very early on. There were people that wanted to do analyses that were clinically trained, but they didn't know how to do the statistical work and the programming that was needed. And so I was brought in initially to look at some other questions. And then over time, there was just more and more going on as the pandemic grew, both in magnitude, but also severity. And then I would say, I believe it was in May, we had an infectious disease colleague come to myself and my PhD advisor and say that they had this really interesting observation from working on the COVID wards, that patients who they thought would not do very well once hospitalized were actually doing okay. In particular, some of the transplant patients and some autoimmune disorder patients. And so while we classically think of immunosuppressed people as being at higher risk, that was not what they were seeing. And so my advisor always says the plural of anecdotes is not data. So we had to go through and do a formal analysis, but that's what started this whole process for us.
Yeah, absolutely fascinating. So just to be clear, people who are immunosuppressed or immunocompromised are at greater risk of acquiring COVID, but what you were looking at what was happening to them once in the hospital setting, to be clear. Yeah.
Right.
Now, as I mentioned, Johns Hopkins has been this great provider of data to the world, frankly. And as you say, it was opportunity knocking, really, because you found yourself situated in the institution and obviously someone who has strong pharmacoepidemiology background. So you were like in the perfect storm of data, so to speak. When you look at immunosuppression, how did you define that? So when you started on that, when you made the pivot and started on this project, I mean, one of the important things about working with data, I imagine, is setting the boundaries for the data.
Definitely.
Yeah. So tell us how you define immunosuppression. I think for our audience, that's a very relevant question.
Yeah, so we decided to define it using medications. So we didn't use diagnosis codes for most of our analyses. We used it in one just to check that our assumptions were correct. But we looked at medications that people reported as being medications that they took prior to being admitted with COVID. So the studies that we've done are not looking at the effectiveness of perhaps using an immunosuppressant in somebody who hasn't used it before solely for the purpose of COVID. These are people taking them over long terms for a chronic medical condition prior to their SARS-CoV-2 infection and their COVID symptoms. And so we ended up using a list of medications as defined by the World Health Organization. They have a classification criteria for drugs and biologics called the Anatomical Therapeutic Chemistry Classification. And we chose to use ATC.
One of those easy WHO to WHO terms, right?
Yes, WHO ATC. I've had $1 for every time I used that in the past year and a half. We chose to use a standard definition because in the research world, it helps to be able to cite something else, but also we were starting in the spring of 2020 and there was particular interest and attention being paid towards some immunosuppressive medications and did they work or did they not work as prophylactic therapy. And so to avoid any undue controversy from perhaps using or not using hydroxychloroquine, we decided to instead use a standard definition, which included chemotherapy drugs and then some selective immunosuppressant therapies.
Right. So not the entire gamut, but a selected list of them.
A pretty large list. We had 303 drugs in the.
Oh my goodness. So
Yes.
We're not just talking about then inclusion of people who are dealing with a rheumatological issue. These are, as you said, transplant, cancer, or chemotherapy patient. Okay. So
Yes.
a pretty big group. So how many people then did you look at in total in this data set?
So at Hopkins, we had about 2,000 hospitalized adults, 5% of which we defined as immunosuppressed. And then we followed up with the larger national study where we had 220,000
Wow.
hospitalized adults, and we had 7% of adults there we qualified as immunosuppressed.
So explain to our audience, Kayte, why those numbers, why the size of data is important in terms of reliability of the answers the data gives you.
Sure. So I think the Hopkins study was really important because it came first and because the data were available to us, and this was an important question that was out there. But the national study allowed us to look specifically at some of the medications. So we had patient groups coming to us after our Hopkins study saying, I'm on this medication. What does your study say about this particular drug? And we couldn't answer that because maybe we didn't have anybody on it, or we had 1 or 2 people and we didn't feel comfortable sharing that one person's experience might be representative of that medication. But when you have hundreds of thousands of people to look at, you have greater opportunity to be able to look at specific classes or specific medications themselves.
So is that what we call power? The study had power to tell us something?
A bit, yeah. So we don't think of it necessarily as power because we take everybody that's in the data set and we use them. So we wouldn't pick people only for the purpose of meeting a goal, but we certainly had enough to choose from.
Tell us what you found. Like, give us the big high kind of the big flags that rose up the flagpole, so to speak.
So we found nothing, which I think is really actually important. Most of the times people think scientists want to have something to talk about, and we didn't. And I think that's actually a good thing because we didn't find that overall immunosuppressive medications increase or decrease people's risk of needing to go on a ventilator once they're hospitalized with COVID or dying with COVID.
But what remains unknown?
I think the biggest question that I still have is about dexamethasone. So at this point, dexamethasone is a steroid medication. I'm sure many people watching this channel are familiar with steroids. Yeah. And dexamethasone is the only medication that we know reduces the risk of death in hospitalized COVID patients. There are some other medications out there that reduce length of stay, but dexamethasone is the only one that's been proven with mortality benefit. And something that I and a few others have been wondering is if the immunosuppressed populations have a different reaction to the dexamethasone, and maybe they don't get the full benefit, especially if people have been using steroids for the long term, if their body just doesn't have the same magnitude of response because they've been familiarized with steroids in the past. So I think that's a really important question that still needs to be answered.
Would it matter if a person, I mean, most of the use of steroids in my community are oral, thankfully, when, you know, but the ones that are used in the setting of COVID are delivered intravenously. Is that right?
They can be used intravenously or given orally. It would depend on how sick the patient is and if they're able to take the pills or not, among a few other things.
Okay, okay. But for you as a newly minted PhD, what was it like putting, you know, the pen to paper, so to speak, and putting this work down and getting it into a journal and seeing it published? What does that mean to you as a clinical researcher?
Well, it was interesting because I have experience publishing in the past, and this was a lot faster.
Yeah.
There was just a lot more both pressure on me, but also the journals are moving quicker. And both of our articles are open source available because those journals have chosen to release the COVID work to the public at no charge. So that was interesting. Personally, I found it very important and rewarding to have done this work and have found what we found, because there was a lot of hesitation, particularly at the beginning of the pandemic, with patients. Should I be continuing to take these medications?
Yeah.
And these are not medications that people take lightly. These are medications that prevent, in the case of your population, perhaps permanent joint damage. And so there's real trade-offs if people are not taking their medications out of a concern that might not play out in the data, but then they then incur permanent joint damage or pain or disability and fatigue from coming off of those medications. So I think the speed at which everything has moved was particularly necessary here, given the risks for your populations and others.
Boy, that's such a great observation. I hadn't really thought of that, about how rapidly knowledge transfer has taken place over this past 2 years. And it makes me wonder why we haven't been doing that before.
Yeah.
Right?
Yeah, I mean,
I just think, I mean, people like me are starving for the things that people like you know. And I understand the rigor of science, that we don't want to make decisions that, you know, out in the street about our health that aren't actually known facts. In other words, they're anecdotal.
sure.
But how do you see what we've learned during the pandemic kind of moving forward in terms of getting knowledge out?
I think there's been a lot more interest in my field. When I started my PhD, not many people knew what I was doing. Even my closest friends, I don't think fully understood what it was that I did.
They do now. They
do now. And I'm everybody's personal COVID epidemiologist. I get texts and calls and questions all the time. So I think it's interesting that the general population is a lot more interested and engaged in health research and in making decisions for themselves as things are changing very quickly.
Yeah, I agree. I think one of the good outcomes of a pandemic is, I think, the increase in knowledge about public health measures. What can we do that are very simple, like masking, washing hands? I mean, those things are kind of universal to not getting a cold, not getting the seasonal flu, and not getting COVID, by the way.
Yep.
And vaccination, of course. So I think those things have been super sort of important outcomes. It also showed us, I think, starkly, Kayte, how low our health literacy is. You know, I really do think most people didn't know all of those things, or didn't know how to act on the advice that they've heard probably forever from their healthcare providers. Sure. And now in pandemic, they've actually seen how it works firsthand in many ways, with very dire, you know, consequences. So, you know, always trying to look for the silver lining here at Arthritis at Home, and help people understand public health issues. Kayte, thank you so much for joining us. We really appreciate your time. Thank you for doing this work. For being that bright, young, eager mind that provided to our community very important answers and guidance. And I hope you get some rest over the holidays, that you're not inundated with more texts and emails and calls about what people should do. You can refer them to this episode and they'll know. How's that?
Sounds great. Thank you so much for having me. It's
Thank
been
you,
wonderful.
Kayte. Happy holidays, and be good and be in good health.
Thank you. Same to you.